Hello.
Hello.
I hope I can be heard.
Yes, loud and clear.
Great. It's beautiful to have all of us join today's meeting. I think Selma wants me to welcome all of us in a special way. We have Dr. Victoria May Adabari. She is going to be the chairperson for our discussions today. Yes, so Dr. Victoria May Adabari is a consultant pediatric nephrologist. She currently practices in the Kolebu Teaching Hospital, the Department of Child Health, the largest hospital and then the main tertiary referral center in Ghana. Working as a consultant general pediatrician as well, she has managed children with various conditions across several specialties, including asthma and malaria, in which she has perennial interest. She's currently the head of the pediatric renal unit and runs the pediatric renal services for the hospital. She is a part-time lecturer with the University of Ghana Medical School and also teaches postgraduate pediatric residents and fellows. She is a member in several professional associations, including Ghana Medical Association, Pediatric Society of Ghana, Ghana Renal Association, and the International Pediatric Nephrology Association. Other responsibilities include examiner, West African College of Physicians, and she is the immediate past treasurer of the West African College of Physicians. She loves listening to music and dancing, outdoor activities, and seeing new places. Ladies and gentlemen, I present to you the chairperson for today's meeting in the person of Dr. Victoria May Adabari. Dr. Adabari, your audience. Thank you.
Thank you very much, Bright. And thanks to all our like-minded guests who are so excited when it comes to the well-being of children. We had a little blip in our care of children when it came to the vaccines, but we are happy now that they have begun to arrive. Today, we would like to focus on the science of the vaccination and learn so much that we can learn when it comes to vaccination. We want to equip ourselves with the knowledge and spread the good news. I'm sure there are so many people we come into contact with that we can spread the good news. So we have so much on the plate. We have so many people ready to share their knowledge with us. So today we will explore so many aspects of vaccination and therefore be able to give our children the best protection against the infectious diseases that the vaccines cover. So I ask you to sit back and enjoy the presentation. We have our moderator, Selma, who will take over whilst I chair this occasion. Thank you all for joining us. And I am sure, very sure that you'll have a very lovely time. Right, I hope you heard me well, and I hand this public forum back to the moderator. Thank you very much.
Thank you so much, Dr. Adabari. We would be zooming directly into our presentation, the business for the day. Our first presentation will be by a specialist pediatrician with the Volta Regional Hospital in Pohwe. He happens to be a part-time lecturer at the University of Health and Allied Sciences, School of Medicine, the Department of Pediatrics in Ho. He is a recent member of Ghana College of Physicians and Surgeons and has a postgraduate in pediatric nutrition from University of Boston School of Medical Sciences. He is an avid volunteer with Operation Smile Ghana and a member of the Pediatric Society of Ghana. He is an enthusiastic people's person. Ladies and gentlemen, I present you the first speaker for today in the person of Dr. Edem Wilson Saba. Edem, please, over.
That was an interesting introduction, right? Thank you very much. I'll be taking us through vaccination, because vaccinations have come up as an important talking point in the last few weeks. We'll look at some concepts, why it's important, and then due to those who have missed, what is the catch-up for these people? Objectives for this presentation are to understand the basic concepts of vaccination and immunization. We'll take a look at, for us to all know what Ghana's expanded program on immunization is, the schedule and the vaccines involved, and to know which vaccines to give in a child who has missed vaccinations. We'll use this outline. So vaccine keeps popping up, and I'm sure most of us have asked ourselves, what is a vaccine? Well, a vaccine is a substance that is, I tried to look for the simplest definition, and I got that from Oxford Dictionary. It's a substance used to stimulate the production of antibodies, which are basically the security system in the, part of the security system in the human body to provide protection against one or several diseases. Vaccines are usually gotten from the causative agent or the organism that is causing the disease, or some of its products. Or sometimes you can use synthetic substitutes, so not necessarily the organism, but something that's prepared in the lab that's treated as an antigen and will not necessarily cause the disease. Now, one common term or two common terms that tend to sound like they're interchangeable and might not necessarily be interchangeable are vaccination and immunization. So vaccination is the treatment with a vaccine to produce immunity from a disease, whilst immunization is the effect of making a person or an animal immune to an infection or protected against an infection. So vaccination is when you introduce a vaccine, and immunization is the effect that you look towards or look to get from vaccination. Now, immunity is basically the ability of an organism to resist a particular infection or fight that infection or toxin. How do vaccines work? In simple terms, vaccines basically use the knowledge of the immune system or the protective system of the body or the security system of the body to mimic an infection. So then it generates what we call an immunological memory, or once the body has seen this infection, it creates a memory bank that stays there and the body now prepares for future infections. So anytime there's a future infection, this memory is recruited, and then soldiers are created to go and fight this infection. To have an ideal vaccine, you need to consider if it's able to provide lifelong immunity from disease and protect against multiple strains of the same disease. Vaccines as well should be safe inexpensive, and should be very stable. So it does not, it can be carried from one point to the other without losing its stability or its efficacy. The basic tenet of vaccine is that you want to induce effective, long-lasting immunity. Worldwide, some estimates suggest that vaccines prevent almost 6 million deaths annually across the world. So in a human is introduced to a pathogen or an infection. These toxins or the pathogen or the microorganism will cause an infection, will lead to a disease, multiple complications or disability. And this eventually, what's causing this, there's an immune response, or if you are not able to mount an immune response, the child might end up passing on. Now for vaccines, it basically bypasses the infections, the disease, the complication, and the disability, and gives protective immune response without the major adverse effects. Now let's take a look at the expanded program on immunization in Ghana. This was launched in 1978. By which time I was not born. I'm sure some of us on the platform were born, and it had 6 antigens or 6 vaccines: BCG for tuberculosis, measles, diphtheria, pertussis, tetanus, and oral polio for children under age 1. Then there was a tetanus toxoid vaccination for pregnant women as well. The program has expanded, and currently there are 13 antigens or 13 vaccines that are on the program. The expanded program on immunization has a mandate, and that is to reduce morbidity and mortality in vaccine-preventable diseases through immunization as an essential component of the primary health care. For those of us who are a bit older, we remember there used to be songs on radio and TV about 6 childhood killer diseases. And this was where encouraging our mothers to send us for vaccination, if we can all remember. Now, just a quick evolution of the weighing card. Previously, we used to have mothers used to carry 2 books, the maternal health records book and then the child health records book. But you cannot separate a mother from her child. So now the book has been combined into the maternal and child health records book for mothers to carry around. So it follows the mother during pregnancy and then follows the child after delivery. Now in this book, which is the maternal and child record books, you find a page that has all the vaccines that a child is due from birth to 18 months. So at birth, all babies are due BCG vaccine and oral polio, and those who are exposed to hepatitis B get hepatitis B vaccine. And it goes on till the child is 18 months. This is readily available in all our maternal and child health record books that our mothers carry around. Now, for catch-up vaccination, because of the acute shortage we had a couple of months, and we must say we are grateful for the response and the fact that vaccines are coming into the country now. There are some number of children that would need what we call catch-up vaccination because they've missed out on one. Now, catch-up vaccination basically refers to the action of vaccinating an individual who, for whatever reason, so delays, stockouts, they are unable to have access, hesitancy, the service interruption, etc., is missing or has not received doses of vaccine which they are eligible for the national immunization schedule. Now, catch-up can be conducted through regular routine immunization service delivery. So, in our health facilities, we have fixed or static child welfare clinics. Sometimes you go out for outreaches. Those of us who are in the districts, for instance, there are mobile clinics where the community health nurses go house to house and vaccinate children. So these methods can be used for catch-up, or you can go to the schools. There's also the periodic intensification of routine immunization activities. So there would be a time where we would have a vaccine immunization program that's targeted one particular vaccine that we have low patronage, just to catch all those who have missed out on it. There are various innovative local strategies that can be used to receive these routine immunizations. But basically what I'm trying to say here is that for those who have missed out on vaccines during this period of acute shortage, there's always the catch-up vaccination. So even though you've missed out on the schedule that is stated in the maternal and child health records book or the weighing card, doesn't mean you cannot get the vaccine. There's always room for catch-up for you to receive, for your child to receive all the vaccines that they are due. Due to the expectation that this could occur at a point in time, WHO has always had a program called Leave No One Behind, and has always provided guidance for planning and implementing catch-up vaccinations, which I expect that our policymakers would implement now that vaccines are coming in, to make up for those who missed out on their vaccinations. So thank you very much, and these are my references.
Thank you very much, Dr. Wilson Saba, for this wonderful presentation. I believe we have all learned something from this one. Next on the bill, we have Dr. Priscilla Al-Hassan from the Northern Region. She's a specialist pediatrician. She's a medical director of Excellent Touch Medical Services Pediatric Hospital. She's a member of Ghana College of Physicians and Surgeons and has postgraduate diploma in pediatric nutrition. She holds a certificate in leadership and management in health. She is an affable pediatrician and looks to fellowship training in the nearest future. Shall we welcome Dr. Priscilla Al-Hassan? Dr. Al-Hassan. I think Dr. Al-Hassan is having some hitches. All right, I think we wouldn't waste much time, and we would go on to introduce the next, Dr. Al-Hassan. Okay, I believe we can go on and introduce the next person. Sorry for the breaks in transmission. Dr. Al-Hassan is projecting, but
Hello.
She's muted.
Yes, sorry, I was unable to unmute myself. I was told
Oh.
it was not allowing anyone to unmute.
Sorry about that. You're on now and we can hear you loud and clear.
Thank you very much. So thank you for that wonderful introduction. And this evening we'll be looking at understanding measles. So what is it that every parent should know or every caregiver should know about measles? So looking at the outline of our presentation, we'll be looking at a brief introduction, the clinical features, or that's the signs and symptoms of measles. We'll be considering the fact that all parents should know about measles. We'll look at complications, and we'll take some take-home notes as well. So what is measles? I'm sure parents would want to know. They've heard there's an outbreak of measles across the country, and they would want to know what measles is. So measles, according to the WHO, is a highly contagious, serious disease caused by a virus, the measles virus. And it's also called rubella. So if you hear rubella anywhere, that is still referring to measles. And usually it's primarily a childhood illness, but measles can occur at any age. In our environment, we have seen it commonly in those less than 5 years, but it can occur at any age. Measles is an airborne disease. And so when a person infected with measles coughs or sneezes, the measles virus is released into the air, and it can be suspended in the air for up to 2 hours after the infected person has left that room. And so we should be aware of this fact. It may also be spread through contact with saliva or nasal secretion. So if a person has coughed up and it has fallen on the surface of a table or a chair or a bed, and another person comes into contact with these secretions, and the person is likely to get measles infection if they are not well protected. Okay, so we want to look at the signs and symptoms of measles. Measles most often would present with a rash. And in medical terms, we would say it's a maculopapular rash, which means it's usually a flattened, darkened or reddened rash, which occur in multiple areas of the skin. So usually it would start from the forehead, spread all over the face to the neck, and then extend downwards to the rest of the body. And usually the rash would come after the fever and cough or flu-like symptoms have occurred. So the rash is not usually the first symptom you would see in a child if your child has measles. And there's usually high body temperature. And these details I have provided here, or this table here, is just a representation of the symptoms that we saw in the Tamale Teaching Hospital in recent times. So as at now, we have about 314 suspected cases, but as at the time we were reviewing this data, it only covered about 119 patients. And we realized that a majority of them came with high body temperature, greater than 38.0. Those who came and at the time didn't have a fever or didn't have high temperature were just about 27.9%. Then those who came with oxygen saturation and requiring low oxygen saturation and requiring oxygen were not so many, if I should put it that way. We see that 61% of them did not require oxygen supplementation as at the time of admission. We see that a large number, a whole chunk, about 96.3% came with cough. And so cough is quite common in measles, at least in the cases that we have seen at the Tamale Teaching Hospital here in the northern region. And then coryza is just flu-like symptoms. So nasal congestion, nasal discharge. We had about 72.7% of them presenting with these flu-like symptoms. And then 22.7% came with conjunctivitis, that is inflammation of the eye. So you see some reddening, you may have your child having some discharge of the eyes, all from the measles infection. And then just about 10.9% came with seizures. And so these are the common signs and symptoms that we'll see in a patient presenting with measles. So with the signs and symptoms, these are pictures that we took actually on our ward in the Tamale Teaching Hospital. So initially they could have their complex spots, which are just whitish lesions or whitish patches that you see in the mouth. And this patient on the left has that lesion. So I think if you zoom in, you'll be able to see the whitish patch in the mouth. And this you would usually come before you see the rash. And most often than not, the complex spots will resolve before the rash is seen on the skin of the patient. Then on the right, we see what we call the maculopapular rash. So this is the typical rash of a measles patient. So I think on the next slide, we see another picture of the rash, measles rash. And then on the picture on the right, we see a patient who has had the rash, but then the skin is now peeling off. We call it sloughing. The skin is now peeling off after the rash. And so this rash is currently in the recovery process. Then we have those who came with the reddening of the eye. So that is on the next slide, with conjunctivitis, which is simply inflammation or infection of the eyes. So some would have reddening of the eyes, some would have eye discharge, which is shown here. So if you zoom in, I believe you'll be able to see it quite clearly. Okay, so what we want every parent to know, or every caregiver to know about measles, is that one, measles can be serious. So measles is not just a little rash, and measles can cause serious complications, especially in the younger age group. So in children less than 5, and more especially if you have a child less than 1 year who has had measles, it can cause very serious complications. And usually at the onset of the signs or the symptoms, it's difficult to tell which patients will have serious disease. So it's advisable that once you have started seeing some symptoms in your child, or you started seeing some things that suggest that your child may have measles, it is better to go to the hospital so that your child is looked at. It's better you go and it's mild and you are asked to go home to manage than to assume it would just be a little rash and then later your child develops serious disease or life-threatening illness. Okay, so the next thing we want parents or caregivers to note is that measles is very contagious. It is so contagious that 9 out of 10 people who have come into contact with one person infected with measles will get measles if they are not protected. So if your child is not vaccinated, if you yourself for some reason has not been vaccinated, or if you have a pregnant woman or a patient with very serious illness which has already suppressed the immune system, and the person comes into contact with a person with measles, there's a 90% chance that your patient will get measles just by being in the environment with the person with measles. Your child can get measles just by being in the room with the person. So your child doesn't have to be in close contact with the person, but just by being in the room with the person, your patient is at risk of getting measles if only they have not been properly protected against measles. So as we mentioned earlier on, for up to 2 hours after the person has left the room, there is still measles virus, which is still airborne in the room. Okay. So we also want you to know that an infected person can spread measles to others. That is between the periods of 4 days before developing the rash and 4 days after the rash has appeared. So this is something you have to take note of and be very cautious. It's possible a person has measles or a child has measles, but has not yet developed the rash. But at that period, the patient can still pass it on to others. So we have to take note and be very cautious. And then 4 days after developing the rash, the child is still infective, or the child can still pass the measles or spread the measles from the patient to another person. Okay. So the next thing we want caregivers to note is that you have the power to protect your child against measles with a safe and effective vaccine. And I think we have just been taken through a presentation on vaccination and the expanded program of immunization that is rolled out in Ghana. The best protection against measles is by giving the measles rubella vaccine. And that is what is given in our environment. There are some countries where it's a combination of about 4 vaccines, but in our environment, we only have a combination of 2 vaccines, which is the measles rubella. And that is given at 9 months and at 18 months. And this vaccine, once it's effective, would give long-lasting protection against all strains of measles. Okay, so we want to look at the grouping of measles or classification of measles. So measles can either be mild or it can be severe. When it's mild, we say it's uncomplicated. And when it's severe, we say it's complicated. So when measles is uncomplicated, your patients would have high body temperatures, which is fever, would come with flu-like symptoms like the runny nose, the congestion of the nostrils, and could have the rash starting on the face, spreading to behind the ears, and then spreading to the rest of the face, and subsequently the rest of the body. And we have learned that the rash would usually come after the other symptoms have started. Then when we have severe measles, and that means all these symptoms mentioned before are present, but there are additional signs of complications or the effects that come from having measles, which include fast breathing, a difficulty in breathing, convulsions, and reduced level of consciousness. So if you note that your child has had any of these signs, then please rush the child to the nearest health facility. Okay. So we move on with the complications we spoke about, or the effects of measles. We have those that happen immediately during the illness, and there are some that happen some years after the illness has occurred. So we call them the short-term and long-term complications of measles. So in the short term, your child can have encephalitis, which is just inflammation or infection of the brain with the measles virus. And then we could have pneumonia, which is infection of the lungs. So your child will start having fast breathing or find it difficult to breathe. And then if you come to the hospital and we check, it's likely that the oxygen saturation of your child will be low. Then the patients can also have otitis media, and this is simply infection of the middle part of the ear. And so we are able to pick it up from the history that you give us, and then also by examining the ears of the patients. But this is another complication which can happen. And in the long term, this otitis media, if left untreated, can lead to deafness in your child. So you see, measles is not a simple rash. And a patient could also develop diarrhea with related dehydration. So sometimes they would come to us with dehydration, or they will come with no dehydration. But you do not have to wait until your child is in dehydration before you come to us. So let's identify these things and come early. Then, because of the ongoing illness, there could be loss of immunity to other diseases. So you see that other diseases that otherwise would not have affected your child will come into the picture because the immune system of your child has been suppressed by the measles infection. Then in the long term, as we said, there could be brain damage, and there's a condition we call subacute sclerosing panencephalitis. It sounds very big, yes, but it's also infection or inflammation of the brain, which occurs because of brain damage that occurs because of measles. But this can happen up to 7 to 10 years after your child has had the measles infection. This is why even if your your child has been managed for measles, we keep following the patients up. And you have to understand that even after the child has recovered, 7 to 10 years after this, the child can still develop brain damage. So please do not hesitate to bring your child back for routine reviews so that we'll be able to pick up any signs of such brain damage and manage as is deemed fit. And then the child can develop blindness. And as we heard earlier on, the child can have inflammation of the eye. So this can also lead to blindness. And then malnutrition can also occur due to measles infection. Next slide, please. Hello. Okay.
Dr. Hassan.
Selma, I
Hello.
think she could have dropped.
She's muted again. Yes.
So sorry, I dropped. I was trying to use my phone to join, but I couldn't unmute. Okay. So we want to look at some of the risk factors for severe disease. So children of a very young age, and as I said, the highest risk factor is in those who are less than a year old. They tend to develop severe disease. And then those who already have malnutrition of any form, they have a risk of developing severe disease. And if they live in an environment where there's overcrowding, it's easy to pass it from one person to another because, as we said, it's airborne. So once there's a child who has measles, coughs into the air or sneezes into the air in an overcrowded room or environment, they easily pass it to other young children in the environment. And then any patient that has immune deficiency or suppression. So if you have a child who has either acquired or primary immunosuppression or deficiency, then this patient is at, or this child is at increased risk of developing severe disease. So in our environments, the commonest acquired immunodeficiency syndrome we have is the HIV/AIDS. And for those who have vitamin A deficiency, they also have the potential to develop severe disease. Next slide, please. Okay, so these are my references. Thank you very much for your attention. I'm done.
Thank you very much, Dr. Hassan. That was a wonderful presentation and very educative. For those of us who were not born in, about 20 or 30 years before the vaccines came, for those of us who don't know anything about measles, we hear measles is an airborne disease and anybody can be vaccinated against measles. Please, some hands are up, but there will be time for question and answers. So shall we please go on with the next presentation? Let's go on with the next presentation. And then there'll be a special time for question and answer section. So we are going to welcome our next presenter to give us our third presentation for the day. He's in the person of Mr. Alexander Nyaba Anafo. Mr. Alex Nyaba Anafo is a nurse at the Tamale Teaching Hospital the Child Health Department, and he has about 14 years experience in clinical work, a year experience at the Wale Wale District Hospital, and half a year in Touchman Holy Hospital. He is also a clinical coordinator of the Ghana College of Nurses and Midwives, Tamale Training Site. He works also as a part-time lecturer at the University for Developmental Studies, Department of Advanced Nursing Practice. He has his pediatric nursing specialization at the Ghana College of Nurses and Midwives, hence a member of the Ghana College of Nurses and Midwives. He has his master's at the Kwame Nkrumah University of Science and Technology, and recently a registered dietitian. His main areas of research and interest include child malnutrition and diabetes. Shall we welcome Alexander Nyaba Anafo for the next presentation? You're welcome, Mr. Nyaba. The host should kindly unmute Mr. Nyaba for the presentation.
Hello.
Hello, Mr. Nyaba, we can hear you.
All right, thank you very much for the opportunity. I'm trying to project, but it looks like, I hope it's not, okay. All right, so thank you for the opportunity and actually listen to the two presenters. We have listened to vaccines and then what the mother should know. And I'm going to talk about home management. And the presentation outline will be the introductory. What are the factors that can hinder the management at home? Talk of home care. And then we'll have nutritional care, danger signs, and then we'll conclude. This is a case managed at the Tamale Teaching Hospital, currently on admission. It's a suspected case. And they already talk of measures, and then we said that it is a droplet airborne and it's spread by coughing or sneezing. So what these are the factors that can hinder the management of measures at home could be that the parents' knowledge level of the conditions, is that the understanding of the signs and symptoms, and then what are the management, what are the precautions to take, so that you'll be able to protect the child, protect yourself, and protect other children from getting the infection. And then the cultural beliefs, there's some other cultural beliefs that have a different understanding of the cause of disease. They may think it is caused by other things, maybe case or something. So the first line of action will be that they prefer to go to where they will get a solution. So the hospital will be their last point. So if there is culture like this in the society, they end up hindering the care at home. So you don't allow cases like that to be at home, because if they follow this, they end up worsening the case, and they will come at a stage where you have to, the health workers now have to struggle. And then the economic status of the family. You have one single room and all of you have about 4 or 5 children staying in the same. And when one is infected and not isolated, it ends up affecting all of you, or all the children, and then maybe carry it to susceptible patients or clients outside. And then lack of vaccination, as it just happened. If you are there, you are willing to send the child to the hospital or for a clinic for the vaccine, right? It is not there. So what can you do? So a case like it, then that means you have 1, 2, 3 at home, and one is having the measures, then it is very important that you should not sit at home. And then if you don't go to a clinic, then you don't get the vitamin A supplementation. And then Dr. Alassane just talked of malnutrition being one of the causes or one of the risk factors that can cause a serious infections, or maybe when they have measles, can cause the complications. All right, so the question I do ask myself is, okay, so which patients are actually adequate or that you can manage at home? And we said that as you listen to Dr. Priscilla, he said all cases have to come to the hospital. So home care here, we are talking about a case you bring to the hospital and then manage and discharge, or a case that you suspect after listening to the signs and symptoms and then the causes that you have seen, then you realize that this case could be one of them. Then what is the first thing to do before you rush to the hospital? And remember that measles management is supportive. You manage based on the manifestation, the signs and symptoms, what the patient is presenting. They don't have a specific management for it. So the first thing is, as you talk of, temperature will be there. And what should you do? So you try to cool down the body by taper-spawning. And with taper-spawning, you don't taper-spawn with a cold water or hot water. There should be a lukewarm water, okay? And then the first thing, you start from the feet. So you start from the legs, pouring the water on the legs, and then you end up showering the whole child, and then you allow droplets on the child for it to dry itself. So you end up cooling down the temperature, and then you have paracetamol, then you give. You can expose the child depending on where you are and the temperature at that time. You can expose, or you wear the child light clothing. That can also help. And if the child is breastfeeding, you encourage continuous breastfeeding, and then you provide oral care. Then you also look at the skin. This is also one of the cases also on admission, currently on admission. And it's very important to protect the skin. And mostly what we use in Tamale Teaching Hospital to protect the skin, and there's pruritus, itching. So you have to find something that can suit the skin and also reduce the itching. Then we use zinc oxide, sometimes calamine lotion, to make sure that at least we use on the body. So we can encourage that at home. If you go home and it's still there, you can encourage that. And you also avoid exposing the body to direct sunlight, okay? And cut the fingernails because there's itching, and you don't want the nails to be long to end up giving sores, and that can lead to other infection. Then the eye care, you talk of the conjunctivitis, there's watering eye. What should you do as a patient, a parent at home? The first thing is to wash your hands. Make sure that your hands are clean and get good water or clean water towards the face. And if there's excretion that is not cleared, then you use clean cloth or cotton wool if you have. Then you soak it in warm water then to remove it. Do not use the dry one because you end up leaving particles or you end up causing more harm to the eye. And don't use unclean thing to clean the eyes. It's very, very important. Otherwise, you end up infecting the child eyes. And another thing is that you should not go and buy drugs on over-the-counter medication and come and start putting, or you knock on your neighborhood door because he went to the hospital or he bought the same thing and the child thing have gone. So just give me and I'll drop. Actually, the uniqueness of individuality is very, very important. We are not the same. We are totally different. And maybe the condition that patient was carrying is totally different. Okay, you encourage them not to rub the eyes. Maybe there's also itching. So you encourage that is to protect the child from using the hand to rub the eyes. Also from direct sunlight, using the eyes on direct sunlight. Hydration is very important. We talk of dehydration. It's one of the things that a big problem. Sometimes they rush them, you are in the water and they rush them in and they are dehydrated. If you are not careful, they run into shock because some of the signs and symptoms could be either he's running diarrhea or he's vomiting. So based on this at home, before you start coming, then you make sure that if the child is still feeding, you continue your breastfeeding. If not, you can encourage oral fluid, or you have your ORS, then you give. If you have your zinc tablet, it doesn't spoil anything. The zinc tablet, you can get it over the counter, and then you can do that. If the child is less than six months, you get 10 milligrams daily. And then if it is more than that, then you get 20 milligrams, then you give, and you come to the hospital and you get appropriate care. Then drink a lot of warm water. Remember, we are talking of this because it's not, even though measles is described as primarily childhood disease, but it's also infect other susceptible, as Dr. Pressler have already enumerated. So when you have it, then you drink warm water help flush out the toxin. And evidence has shown that when you get your warm water and you get other ginger or lemon, then you put it small on it, half a cup, and then you drink, at least you drink empty stomach in the morning. When you wake up, then you take it, and when you are to sleep, you take it, it helps. Please, it doesn't cure any disease, but it helps boost your immunity. So it helps protect the child from running into serious complications. And even if you are an adult, but remember, if it is still breastfeeding or still doing exclusive breastfeeding, please continue your exclusive breastfeeding. And then make sure that the child stay away from the public, or even if possible, you can do some small isolation for the child at home. As it is already said, the first 4 days before the rats appear, and then after another 4 days, then that means is the dangerous area, a period that they can easily spread. So at this time, you have to protect the child, protect yourself, protect the other vulnerable, like the under 5, as it is said already. Then you avoid the vulnerable yet to be vaccinated. You have a child who is yet to be vaccinated, and you realize that you have another one that is having running nose, coughing, sneezing, then you protect that from the other group. And you continue to wash your hands. Hand washing is one of the powerful way of reducing infections. And then you use the alcohol-based swabs to clean the surfaces. We said that it is airborne and droplets. Okay, when you sneeze it out or you cough it out and it stay in air for some time, fall on the surfaces around. And they said it can move about 3 feet from the patient. So 3 feet from the patient, just expect that all those areas are infected. Then you make sure that you clean it with alcohol bases, and then you wash your hand yourself, and then you make sure that the child also wash the hand. And if it is appropriate, if the child is somebody who can take instructions, you can say that anytime he's coughing, then is to cover the mouth or cover the mouth if that is it. But if it is a small child, it's not possible. And the toys he's used to play, you make sure that you clean them with detergent. Ensure that the roof and the surrounding are clean and tight. Avoid sharing toiletries. You don't use towel for more than 2 children, or they exchange clothing. It's not the best, okay? And then measles patients should be kept in a well-ventilated room. And one of the determinants of measles outcome is how well or where the patient stays. Is it crowded or is well ventilated? Okay, when it is crowded, it leads to even more infection with other opportunistic infections, other infections that comes in, and because the immune system goes down. And because of that, the child can come with complications. And you make sure that the child has enough rest because it speeds up recovery. Continue your breastfeeding. I continue saying the breastfeeding because it's very important. As I said, we have a lot of determinants of the measles outcome when you get the infected. And that's why when you look at the small children, less than 3 months, measles is rare in those people because they have the immunity from the mother and from the breastfeeding. So because the breast milk also form as an immunity for the child. So you continue your breastfeeding, also boost the immune system and also boost the nutritional state of the patient or of the child. So when he even get the measles, if there's no vaccines and he even get the measles, he will not get to the critical point where he needs oxygen and then breathing for the child and those things. So it's very important to continue. And then make sure that as the temperature subsides, make sure that you feed the child with high biological value food, like lean meat, fish, eggs, and remember, and then you can also add the vitamin A and vitamin C sources of food. But you should remember that when the child is critically sick, the digestive system is altered, and vegetables sometimes they doesn't digest well, and there's chelators, and these chelators hinder the absorption of other vital nutrients. So, and the child have to use a lot of energy to metabolize or to digest those ones. So the best thing is to go for animal sources. The animal sources is fully, they have all the essential amino acids. So when you give, it's easy to digest, and they end up building more tissues, so the child will not get malnutrition. Okay, then you reduce fatty food and then processed food. You also make sure that you avoid caffeinated and sugar-sweetened beverages. All those you see in the stores are all sugar-sweetened beverages. They don't add anything apart from empty calories. So for a child who is sick, you don't want to fill the stomach with unnecessary things. You will need nutrition for this child. So you avoid from there. And then, caffeinated, the more you take them, the more you urinate. So you end up losing more fluid. And when it's running diarrhea, then you are sending this child to a dehydration and to shock. So now that the child is sick, you also lost appetite, eat poorly. Don't force food to fill the stomach. Always encourage the child. When you take 1 or 2 spoons, praise the child, and serve the food in a very bright bowl that the child likes. And then you feed slowly, small, but do not force it. And what are the danger signs? As it's already mentioned, when you see any of this, when you are discharged and you are at home and you see any of this, please rush back to the hospital so that proper intervention can be instituted. When you see that the child is feeding poorly and when he's having difficulty breathing, the temperature continues to go up and he's having seizures, there's loss of consciousness. You think that this child was active, now he's becoming dull, okay, then you make sure that you come back. And when you keep on vomiting everything out, anything you give, you vomit it out. So you have to come and then we start the IV fluid. And also when it's running diarrhea. In conclusion, I said that measles is a vaccine control infection. It's very important that we should make sure that our children are vaccinated. And it's also very important that we, the parents and everybody, should be an advocate for the child. Make sure that those who are supposed to provide it with the vaccine actually put pressure on them to provide the vaccines to save the children. They used to say that women or parents will say that you count your child and give a name to that child after he recovered from measles. That was then, but now it's not like that. Measles was not something some of us have even seen. It's just recently that we now even start learning about measles. So it's very important that we should be an advocate. And we should also make sure that at least when they go, even after they finish the 18 months, the vitamin supplement is to continue to go for the vitamin supplement till 5 years and continue breastfeeding. The child is feeding. Make sure that the child is fed nutritious food and avoid junk food. The ready available food that you can just pick from anywhere, but make sure that he eat nutritious food so that he will not get malnourished after the measles. And then hand washing is very, very important. Thank you very much.
Wow, thank you very much. Thank you. We are grateful for this wonderful presentation. So we also learned that there's home management for measles as well as hospital management for very critical cases. Yes, thank you, Mr. Nyabanafu. And please, as we go on, we are getting to the next stage of the program for this evening. I just want to alert everybody that we have our social media handles at the bottom of the flyer that we posted. On Instagram, we are paeds.gh. Paeds.gh. The spelling is PAEDS.gh. PAEDS.gh on Instagram. On Facebook, we are Pediatric Society Ghana. Pediatric Society Ghana. Pediatric spells capital P. Society, it's a one word, sorry. Pediatric is capital P, Society capital S, and the GH is capital G. So Pediatric Society Ghana on Facebook. On Twitter, we are Pediatric Society _Ghana, sorry, PAEDS Society, PAEDS Society _Ghana, PAEDS Society _Ghana on Twitter. And then on YouTube, we are Pediatric Society of Ghana. It's a sentence, it's not one word. Pediatric Society of Ghana on Instagram. And we have a few sponsors we would want to acknowledge. We acknowledge UNICEF for supporting us. We acknowledge UNICEF for supporting us. And of course, our own Pediatric Society of Ghana, who is making sure this is coming up to support what is going on in the country. So that is for sponsors and then our social media handles. At the moment, we have gone to the next stage of the presentation. We are now giving time. We are giving time for questions and answers. Questions and answers. So please, question and answer time. So we'll be looking into the chat box for questions. We'll be looking at hands that are up. If you have any question you haven't put in the chat box, can you please raise your hand up and then we will call you. Our resource persons and chairperson are all available to answer you. So the first one I see here is Maria Abu Puvila. Maria Abu Puvila, followed by Christopher Akpa. Madam Maria Abu Puvila, please ask.
Thank you very much. My name is Maria, resident GCNM, Tamale Teaching Hospital. I'm so grateful for the enlightenment this evening. I thank all the presenters. My question is, okay, before my question, I've really been enlightened that with the measles, it's basically three systems that are affected: the respiratory, the immune system, and then the skin. Well noted. But my question is, with organ enlargement, I've actually seen it in the ward where we have a child with severe measles, with enlarged liver, enlarged spleen. I want to know how, like, that comes about. How is it related? And then my next question is, we know it is highly infectious per all that is said this evening, but then our centers are full and we have currently about 4 or 5 cases in the ward mixed with other children and then staff. I mean, I don't know, is there something that Mr. Alex or anybody can help me understand? Because as health workers, we are supposed to be patient advocates. And so whatever we'll do to ensure that everybody is fine, everybody is protected, everybody is taken care of, we should do. So I don't know, I don't understand why the other cases, as severe as they are mixed with other children. I'm actually doing my home facility currently at the pediatric emergency room. Thank you.
Thank you. So we call.
All right, thank you. Your question has been, sorry, Selma.
Yes, please. Any of the resource persons.
Yes. Yes, Selma, thank you. Thank you for the question. The question has been well noted. We'll take them in batches of 3 so that we would answer them accordingly. And before we go on and take the next person, we would want to acknowledge one of our seasoned resource persons. She happens to be the Deputy Director, Health Promotion Division of the Ghana Health Service, in the person of Mrs. Mabel Kisiwa Asafo. Mrs. Mabel Kisiwa Asafo, we are very happy to have you, and she's kindly obliged herself to give us all the knowledge and experiences that she has acquired in her office. So Mrs. Safo, we are happy to have you. Dr. Victoria May Adabari, our chairperson, a strong advocate for childhood immunization. She is also she's a chairperson and Dublin as a resource person as well. We are grateful as well. And then all the three speakers, Dr. Wilson Edem Saba, Dr. Priscilla Al-Hassan, and then Mr. Alexander Nyaba. They are going to be our resource persons. So we can see another hand up. And then of course, Mr. Co-moderator, Dr. Bright Daniel, as part of your resource persons. Christopher Aqua, kindly unmute yourself and let's take your question.
Thank you very much, and thanks for the opportunity. It was a nice presentation. My name is Christopher Mama Aqua, medical officer at the Department of Child Health, Korle Bu Teaching Hospital. My question goes to Dr. Edem.
Mr. Christopher Aqua, you're muted.
Have missed or babies have missed the vaccination. If you encounter a baby or a child that, due to one or two reasons, I've encountered one before, that the mother said, I traveled to my village and I didn't take my book along and I couldn't do it. And the child have missed several doses. So I want to know, at what age can the catch-up vaccines be given? Thank you.
So we'll take the third question. Martina Karimu, please go ahead.
Good evening. Please, I want to find out, during the management of a child with measles, when the child is vomiting, is it right to give an antiemetic? And then also for women who choose not to breastfeed their children, especially those who have HIV, when should their child get measles? We were told that we should encourage breastfeeding. What can we still give the artificial milk to them since they have been on artificial milk since birth, or there's an alternative to it? Thank you.
Okay, so this to all of us resource persons. If you are ready, just unmute yourself and go.
Okay, so this Edem Saba, Dr. Aqua, so your question was on catch-up. You meet a child that has missed vaccinations, multiple vaccinations, and needs a catch-up. So there isn't a limit to when the catch-up should be given. Let me rephrase that. There isn't a limit to when you should initiate the catch-up, but the vaccines are given based on each vaccine and the age at which it should be given. There's a minimum age at which it should be given. The maximum age is 5 years for most of the vaccines in our EPI. If you meet, since we are talking about measles for now, let's say a child you meet who has missed measles at 9 months, at any point in time you meet that child, the child receives the first dose of measles. If the first dose of measles the child is receiving is at 18 months, you repeat the second dose at 4 weeks after you've given it. But if the child is meeting you less than 18 months, you give the first dose and repeat the second dose at 18 months. That's for measles. Some vaccines like BCG, you need to consider how old the child is before you give the vaccine. So it's vaccine dependent on which vaccines the child has missed and at how old the child is. That's when you take the decision to give the vaccine. But the point here is that even if you've missed a vaccine, or like he said, you traveled, and we travel quite often, you went for a funeral and you missed out on the vaccine, it shouldn't stop you from coming to the hospital for the child to be, for the health worker or the public health nurse, the doctor, the pediatrician to decide if this child needs to get the vaccine or not. So always bring them in. Don't hesitate to bring the child in for the vaccine, for it to be considered as whether the child should receive the vaccine or not.
Thank you so much, Adam.
Dr. Daniel.
Yes, Dr. Dabari, please go ahead.
Yes, so I just want to emphasize what Dr. Wilson Saba has told us. Do not give up if your child has missed any dose. Bring the child to the hospital. If you have pediatricians around, the catch-up vaccination can be individualized and your child would be covered. There are boosters for some of these vaccinations, and so older children can get some of these vaccines. I want to remind all families, all parents that there are vaccines and times that your child can get the vaccines that you missed. So I hope everybody will take advantage of this. I know sometimes in our bid to care for these children, we get upset when parents delay or miss. But please, we entreat us all that for the welfare of the child, it's better they bring the child to us late than never. So please come, even if you've missed your vaccine dose. Thank you, Bright.
Yes, thank you so much. Mrs. Asafo, do you want to take the question on the
Okay, so
HIV positive mother breastfeeding?
Hello.
Yes, go ahead.
Okay, so I think that with the breastfeeding, currently the fact that a mother has HIV does not prevent her from breastfeeding her child. Now there are medications around such that as soon as mother is diagnosed of HIV, mother goes on ARVs. So she's taking her medication even while she's pregnant, and then the baby is also given medication immediately the baby is born. And so because of that, that doesn't prevent her from breastfeeding. So they do breastfeed with early cessation. So you do exclusive breastfeeding, and then we'll cease, I think, at 1 year. So instead of the normal one stopping at 2 years, the mother who has HIV and has given birth, while she's taking her medicine and the baby is also taking her medicine, can continue to breastfeed. So she didn't have to need to go on artificial milk because the mother is HIV or baby is excluded. And I think that's also on the question of a lot of infection cases also coming around in the hospital, such that babies are being nursed together with those who are not infected. I think that is something that the hospital will also have to look at, so that at least there will be some kind of barrier nursing, such that the people will not, otherwise the infection is going to spread to other babies. So I think this one, the hospital would have to look at it and try and get some other cases. Isolate this cases such that they don't mix up with the other cases. the spread of the infection. Yeah, thank you.
Okay, hello.
Oh.
All right, thank you. So before we give people some questions via the correspondence that was put out earlier. So someone wants to know that, can parents give herbal medicines to their babies?
Please come again with the question.
Can parents give herbal medicines to their babies whilst they await the vaccines?
Hello. Dr. Daniel.
Hello.
Yes.
There's also another question in the chat. I don't know if I should add it.
Yeah. We'll take those in the chat. Just some people have sent personal messages via the correspondence we gave earlier. So that was one of them. The other one mentions that people say that vaccines are linked to long-term health problems, especially diabetes and autism. Is that true?
Hello.
Yes, please go ahead.
Yes, actually, I think the previous question, I think there was a concern about nursing the suspected case together with other patients in the hospital. I think there was a question like that. Yeah, so I just want to add that TTH have an isolation area, isolation site for suspected cases. And anytime the case comes and we suspect, we send this case to the isolated cases. But actually with the cases currently in the world, when we were doing the presentation, we said that the first 8 days before the appearance of the rashes, and then after the 4 days after the appearance of the rashes is the contagious area, or the days that it can easily spread. That doesn't mean that the rest of the days cannot be spread. But the issue is the cases, as he was talking about, are cases that need critical care. So because of that, we don't have specific isolation area that can care for those who are in critical cases, because they are on oxygen and are on monitoring and even resuscitated once a while. So based on that, we believe that even though they are out from the danger where they can easily spread to the rest, but we are still doing the barrier, individual barrier nursing, to make sure that at least the mother, and then whatever we can do to make sure that it doesn't maybe transmit any other to the other side, taken care of. All right, thank you.
Please, can I come in a little bit?
Kindly go ahead.
Oh, yes. So I don't know, but with the PID emergency, I mean, we are all health workers here, so I don't think there is anything wrong with saying something here. There is home. So from court to court, the distance is, I mean, from court to court. Yeah, hello?
Hello.
Yeah, yes. Hello, I'm with you.
So unfortunately, we are all not health workers. It's a public forum, so we have people who are not health workers on the call.
Oh, okay. All right, fair enough. I mean, later then. Thank you.
Yes, please. Thank you so much for understanding. So I'll take the easier questions. Please, herbal medications are not replacement for vaccines. Vaccines have been studied. Their side effects are known. How to deal with these side effects are also known. They undergo vigorous testing, vigorous stages of testing, right from things that may happen in the lab to rats to animals and then testing in humans and all. And this is rigorous testing. And then herbal preparations cannot be used as substitute for vaccines. Thank you.
Okay, right, Dr. Daniel. So yes,
So,
let me take
Sorry, Dr. Daniel, can I also add that it is not only for vaccines, but in general, we do not know too much about a lot of herbal medication. So apart from not using it for vaccines, it is quite dangerous to give your young child or even your child, or even extending it to yourself, herbal medication. So we in the medical field do not recommend herbal medication. It can actually affect so many organs, your liver, your kidneys, and much more. So we do not recommend herbal medication. Thank you.
Absolutely. Thank you very much, Dr. Dabari. Yes, Adam.
Yes, so, I'll take the question on vaccine and its association with chronic illnesses or long-term illnesses like diabetes and autism. So I think autism was the most popular one a few years back. So far, vaccines have been monitored for over 50 years, and each and every day, articles come in looking out for their side effects, adverse events, and to date, there hasn't been any conclusive evidence to suggest that vaccines cause these long-term conditions. Vaccines go through rigorous testing, as Dr. Daniel stated earlier, with testing to various stages before they are introduced to humans, and they are continued to be monitored for adverse events, and so those long-term conditions so far have not been associated with vaccines. Thank you.
Hello.
Yes, you can be heard, please.
Okay, so I must, to add to that, I must say that some of these things are just misinformations that make people ignore vaccinations and other things. We all know that vaccines and immunization have really helped so much that it has really reduced a lot and numbers of the childhood diseases. I mean, I think I read about 3 to about 5 million childhood deaths have been prevented because of these vaccines and immunization. So it has really helped. And if we have any investment, like making our children, giving them the future, then it is vaccinations and immunizations. And so we should know that these things have helped us. It has been studied long ago, even Ghana, since a doctor presented, we realized that it was introduced since 1978. It's about 45 years old. And it started elsewhere before they were introduced to Ghana. And since then, I think our population has been protected dearly from all these childhood diseases. And now we shouldn't prevent our children from getting this opportunity. So we should all encourage people. We realize that most people who will not take vaccination is sometimes because of their own personal beliefs and some other things, their influences or their healthcare practices and all that, which we are all knowing that if we are not able to encourage our populations to be able to take up this vaccination, it wouldn't help us in the future. Our children, we are not doing them any good, and therefore we are supposed to encourage them. Some of the reasons when we listen, we realize that they are just because of their own beliefs, their religious and traditional influences, and sometimes they are even low perception about the entire condition. They think that they have other deity or supernatural powers that will protect them. But we shouldn't forget the fact that vaccines have really made us who we are today, and it is what will make us in the future a proper nation and a proper people or population. And therefore, we should all be vaccine advocates and ensure that our children are vaccinated. So we are happy that measles vaccines are coming. I'm sure more and more are coming as we have been told. Let's all encourage those of us who have mixed. Let's hurry to take our children for the vaccinations, and then also encourage each other to get vaccinated for a proper, a happier population. That is just my submission. Thank you very much.
Thank you too very, very much, Madam Mabel Asafo. Yes, so we continue with the questions and answers. And there are a couple of questions in the chat that I would like to read for our resource persons to kindly answer for us. One person says, what's the difference between antigen and antibodies? That's the first question. And another one says, if a child recovers from a suspected measles, do we still give measles vaccine? For instance, in this period that we are, that some have already gotten, if they recover, do we still give? That's the question. And the next question is also, if a child recovers from a confirmed measles, do we still give the vaccination? So please, over to you, our resource persons, to finish us with the answers. Thank you. Anybody at all can please unmute and respond to the questions.
So I'd like to take the difference between antigen and antibodies.
All right.
Okay, so antigen is basically a part of the germ or the organism that's causing the infection. And when this is introduced into the body, the body's response or activation of the immune system, or I like to use that as the security system for the body, is the immune system, will produce antibodies, what we call antibodies. And these are what will go and fight the antigens, or the part of the organism that's going to cause an infection. So that's the main difference between the two. So antibodies are from you, a human being, and antigen are foreign things that are introduced to you for your immune system to fight. Thank you.
Thank you, Dr.
Hello, this is Priscilla.
Yes.
Yes, I think before then there was a question asking me if we isolate patients in my facility. And I think Mr. Alex has spoken about that, but we have a 15-bed infectious disease center where we isolate measles cases. But as we have already acknowledged, the cases are so many that the 12 beds that we have available to us there are not sufficient. And so usually we try to triage so that if the patient is considered to still be highly infective, we try to isolate in the infectious disease units, and those that we consider to be medium to low risk, we may have to admit to our emergency and subsequently to our main ward. And that has been a challenge, but I think the Ghana Health Service and our public health unit came around, and I want to believe that issue is being addressed. And sometimes there's been an issue with oxygen availability at the infectious disease center. So that has been a concern. But currently the cases we have at my emergency ward are considered low risk or not as infective because they are past the 8 days period. Then I would like to tackle the question of if a child recovers from suspected measles, do we still give the vaccine? In our environment, once we have not confirmed that it is measles, it is safer to err on the side of caution. So it's safer to immunize this child from measles unless it is a confirmed case. So in a case where it's confirmed measles, from what we know, measles confers lifelong immunity on the person, and it is even more effective than giving them measles vaccine. because the body is able to mount a better response to the measles virus itself. And so I think this is, I don't know if it's clear, but with a confirmed case, usually we wouldn't go ahead to give the measles vaccine, but with a case that is suspected and we don't have laboratory confirmation that it's measles, it's safer to go ahead and vaccinate. Thank you.
Yes, thank you very much. Thank you for that.
And
So there's
Selma.
Okay. Yes,
Yes,
please.
and
Come
we
on.
should also remember that we need 2 doses. You know, when it comes to the vaccines, you give one at 9 months, and then you give the second dose at 18 months. So yes, it will not be too much, especially as we were told by Dr. Alassane. If we haven't confirmed it, it's safer to give the vaccine to the child. It's very, measles is very contagious and can be very dangerous as well, as Dr. Anaba told us, that there can be danger signs. So it's better if we haven't confirmed the measles to give the vaccine.
Yes, please. Thank you very much for that, Madam Chair. So please, more questions here. Somebody says, sorry, how effective will a vaccine be if the route of administration has been changed? How effective will a vaccine be if the route has been changed? Let me look for more questions. Can a child less than 9 months be vaccinated against measles? And then the next one is, okay. Can a child who, okay, the same question somebody else asked. Yes, please. I think these are the main questions for the topic now. Others are asking about slides, but please, resource persons, 2 questions. Can you please do it for us and then we go ahead? Thank you.
Okay, so
Yeah,
this is
so,
Priscilla.
yes, thank you, Selma. Let me attempt the routes of administration. So most of these vaccines, again, its administration, the route of administration have been studied. And if a medication is supposed to be given into the muscle and you give it under the skin, it may not be able to stimulate the body to produce the protection that will be needed by your child. That said, all healthcare workers, those who are frontline in giving vaccination, have been trained and have the expertise to give the vaccines via the routes or the ways that it should enter the body. And again, there's need for retraining, of course, so that people don't lose skills over time. But as far as we know, Ghana has one of the most robust immunization or vaccination setup. And those who are giving the vaccines are making sure that the vaccines they are giving to you are in good shape, they have been kept well, and they know how to introduce this vaccine into your child. Yes, so let me just leave it as that. Thank you.
Okay, Selma, so I'd like to take the question on whether a child less than 9 months can get measles. Yes, a child less than 9 months can get measles. And in my facility at Tamale Teaching Hospital, we've had cases who are 1 month and above getting measles. So it's possible for a child who is less than 9 months, hasn't even gotten to the age where they would have gone for the measles vaccine to get measles. And then I think there's another question asking if the child has not reached 9 months, but has recovered from measles, if the child should be sent for the immunization at 9 months and 18 months again. I think we've already established that once it's not a confirmed case, then you would still have to send your child for immunization at the 9 months and repeat again at the 18 months. But if it is a confirmed case, then you may not need to do so. Thank you.
Yes, so thank you very much. Emmanuel, upon your hand is up. Please go ahead.
Yes, thank you, Mike, and thank you all to your resource persons. Excellent presentations. So it's on the issue of, I think Dr. Lassan just addressed that. If we think that a child has had measles before, let's note that a lot of illnesses can look like measles, especially now that we are seeing a lot of children come down with viral infections. They can look like measles. So there is hard evidence. We need lab evidence that indeed it is measles. So it is not a substitute. Our suspicion of measles is not in any way saying that you shouldn't go ahead and give the measles vaccination when it is due. In fact, even in older populations, even when we think you have probably been vaccinated against measles, and we have a reason to think that you are still at risk, we can still give you the vaccine. So let's not worry about giving you a vaccine, even if you've had a disease before. We have no reason to think we are putting you at an undue risk. Rather, we are then adding to the certainty that you have been immunized or protected against measles. Thank you, and over.
All right, great. Thank you so much, Dr. Opong. Let's keep in mind that there are people who are at high risk of severe illness or complications of measles, which includes adults who are more than 20 years, pregnant women, children who are below 5 years, and then children or people who have immune system. Dr. Opong mentioned going for the extra dose of the vaccine. If you're on the call, you have any questions, you can take. Yes, Charlotte, you can go ahead. Okay, Charlotte doesn't want to talk to us.
A few questions in the chat. Right, can I read the questions in the chat?
Yes, Selma, please go ahead.
Okay, somebody says, please, what are the risk communicating methods put in place to ensure that we do not leave any child behind? Okay, this person wants to know what we are doing to cover every child nationwide. Okay. And then somebody says, thank you very much for the feedback on breastfeeding. I asked the question because some mothers are aware that it's safe to breastfeed for the first year of life. If the child is below 1 year, what is to be done when child is on milk substitute only? Okay. And then again, please, with the issue of breastfeeding in HIV-infected mothers, how sure are we concerning compliance? And in situations where we know compliance to ARVs is negative, what is the other option of feeding aside breast milk in babies less than 6 months? So please, these are the questions. Over to our resource persons. Thank you.
Okay, so I think that this HIV question 1 is answered in the earlier submission. What they want to know is, how sure are we that the people will be compliant to the ARV? It's all about our adherence counseling. So once the mother is identified during pregnancy to be having HIV, she goes through counseling and adherence counseling as well to also explore all her difficulties or her motivating factors that will help her, and then the effect of she not taking the medication, because we know that mothers who get pregnant, who are HIV and get pregnant, when they take their ARVs, they can give birth to children who don't have HIV. So babies can escape HIV if mothers take their medications. And therefore, it is not a cut and stone that once you as a mother have HIV, by all means, your child have HIV. So we encourage them to take their medications during pregnancy to bring the viral load down so that the infection rate would also be down. And by so doing, babies that are born to women with HIV are also known to be exposed. So we don't also leave them. They are also given ARVs. So studies have gone on in all these areas to show that when mothers take their ARVs and babies also take their ARVs, they are able to prevent babies from contracting the infection. And then also, there are also tests to also check. At 6 weeks, they do the PCR to check whether baby has it. And then at 18 months, they also check to see whether baby has the infection or not. Then they treat actually the baby. But mother will continue to take the ARVs for life once he sees that he has it. So because of that, and looking at the effect and the importance of breastfeeding vis-a-vis malnutrition, it is encouraged that mothers can take their medications and then continue breastfeeding. So we don't prescribe formula feed because mother has HIV. So we have to encourage them and then do the adherence counseling very well so that mothers will adhere. No mother would want to avoid medication and then put her baby at risk of contracting HIV. So if we're able to do the counseling when they would adhere and then prevent their children from contracting the disease. In the case of communication, race communication, now that we know measles is affecting a lot of people, we just have to let them calm down. Measles has a cure. I mean, we can treat it, we can prevent it with vaccination. I think this thing is coming up because of the shortage in recent times. And so once we are having it, we just need to encourage them to go back to our previous vaccination routine vaccinations so that we'll be able to catch up all those that have missed, be able to catch up. And so our communication and education should be at all levels in our various communities, in our radio stations. So all the districts and regions are being encouraged to continue the education in our facilities as well at our OPD sessions. Let's continue to encourage mothers so that those who even come to the facility and are not even at CWC, at OPDs, they will know about it so that when they go home and they get to, they have anybody at home who hasn't or has missed any of these vaccinations, will quickly bring them to the facilities to come and catch up with their vaccinations that they have missed. So we have to use all channels of communication, radios, interpersonal, using healthcare workers, outreach programs to educate them at all levels so that the information will get to everybody, every Ghanaian, and then children who have missed their doses will quickly go to the facilities to take their vaccinations. Thank you.
Thank you.
All right, thank you so much. Most of our teachers would tell you that they saw cases of measles whilst they were growing up in their profession. For most of us, it's just in recent times that these cases are coming up. And it tells a lot on how much protection these vaccines give us. So I think there was a question on the chat. So since we are seeing measles in children under 1 month, shouldn't we bring the first dose forward, say 6 months? Dr. Alassane, if you are on, over.
Well, it's difficult to bring it forward, given that even at the 9 months and 18 months, we have run short at a point. So it's difficult to do so. But I think if need be, that can be done. So it could be done in consultation with public health units and various stakeholders. But it's not impossible to do so. Thank you. Over and out.
As it stands now, the national policy that is given at 9 months and then 18 months. Some countries give them at earlier periods. So like Dr. Alasan has mentioned, this would need extensive stakeholder consultation. There is a question here. Angela.
Sorry, Bright, can I add something, please?
Yes. Dr. Dabari, please go ahead.
So the reason why we do not give it earlier is because we have antibodies being passed from the mother to the child, and it takes a while to clear. So it looks like there are soldiers already in the young child. So if you immunize early, the number of people who will develop their own immunity, their own soldiers, is not that high. That is why we wait till 9 months. Elsewhere, where measles is not that common, they even wait till 15 months. So for now, it's better for us to give it at 9 months. And it's not going to be that effective if we give it much earlier at 6 months. So that's another reason why we chose the 9 months for immunization with measles in particular, because of what passes from the mother to the baby. Thank you, Bright.
All right, thank you so much, Dr. Dabari. So Angela, please, you would have the opportunity to ask your question. Someone is asking that, won't I overload my baby with all these vaccines that my baby received?
Okay, right. So on a daily basis, the newborn is introduced to different infectious organisms just by their interaction with the environment. And this, the immune system or the security of the body goes on to fight these organisms. And vaccination is basically an introduction of this infectious organisms in a milder form, just to get the immune system or the security system to get used to them. And even if you give a lot of vaccines in one day, there hasn't been any proof that the system will get overloaded. The system will be able to manage and form memory so that in subsequent infections, when the proper infections come, the soldiers will be ready to fight this infection. Thank you, Right.
All right, thank you so much. Angela Opoku-Bona, please go ahead.
Hello. Yeah, good evening. Thank you so much for the presentation so far. And my concern has to do with facing some realities on the ground, especially with HIV patients. I've encountered some, not necessarily nursing mothers, who are still in self-denial. And I know there are some conditions like mentally unstable nursing mothers and some other conditions that do not put the mothers in the position to breastfeed. So assuming you have such a case where a child developed measles under 6 months and we are preaching the issue of exclusive breastfeeding, but in reality, it's not possible to breastfeed, then what will be the other option? It's not that I'm encouraging formula feeds or something, but the reality on the ground is sometimes there are challenges with breastfeeding, and we are looking at malnutrition and measles. So in the case where breastfeeding is not an option, what do we advise? Thank you.
Thank you. Alex.
Hello. Hello.
Yes, please go ahead. Yes, go ahead.
Yeah. Yes. Thank you. Actually, the important thing is that yes, if due to some certain circumstances, the mother is not doing breastfeeding and you are giving other food. So at that time, you are trying to prevent malnutrition. So you continue with the feeds you are giving, but make sure that whatever you are giving contains a lot of nutrients that can support tissue build-up, okay? Because at that stage, there's nothing you can do again at that point. If, for instance, you are not breastfeeding, then definitely you have to continue with the other foods that you think that it is good for the child. And the child can survive based on the food you are giving. And then you also send the child for the other vaccination, apart from the immunization, which is not available, so that it would protect the child from other infections that can end up reducing the immunity. And then the measles can even cause more harm. Okay, thank you.
All right, thank you.
Thank you very much. Thank you, Mr. Alex. Yes, please. We are grateful so far to our resource persons for the information shared so far. We still have a few questions and we have a few minutes to close, but then we'll try and respond to all the questions before we close. Somebody is asking, how sure are we that the vaccines that were currently brought into the country are FDA tested and certified? How sure are we, please? That's a concerned parent. And another question too is, some of the question, yes. Another question too is the weight of the baby taken into consideration in regards to the dosage given? That's the second question. Can we please get our resource persons to kindly attend to that for us? Thank you. Dr. Sava.
Okay, let me try and answer. In terms of how sure are we that they were tested, I know that yes. As a nation, we have I think a bigger committee, isn't NITAG, or a group that imports or buys Gavi and all that makes sure that vaccinations are available to us. And so this is something we have been doing. We are not starting these vaccines today. It has been in the system for quite a long time. And so the same processes that we followed are the same processes that is continuing up to this stage. So I don't think that this is different from all the processes that we have followed since 1978 in bringing vaccines to the country. So I believe that these things also followed, these particular ones have also followed due processes through FDA and every process that they need to come to our country. And then in terms of the weight of the vaccine, I think that this is a dose for all, and it is for every child. It's such that 9 months old and then 18 months is the same dose for everybody. No weight is taken into consideration. So I was trying to see whether I will find the dose, but whatever it is, the number of meals that is given is the same for all age group.
Soma, just to add to what Madam Asafo said, we tend to find a lot of preterms that we want to wait for them to gain weight before vaccination is started. If you consider that preterms are the ones who are at most risk of this infections, weight doesn't play a role in the dose of the drug. So we should administer to both preterms and term babies as well.
I think it's 0.5 mils. Yeah, just 0.5 mils. Yeah. Yes. Okay. Oh, thank you very much.
Exactly. Okay, so Selma, over to you, moderator one.
Thank you. It's exactly 6 p.m. And I'm sure, and I know we all agree that the presentation has been wonderful, simple for all. We tried not to use a lot of our jargons, medical jargons, so that anybody will be confused. We try to make sure everything is well understood, clarity given. So we are very grateful to our chairperson, Dr. May Adabayere. We are grateful. God bless you for sharing the program for us. And we know that is not all. Our presenters, Dr. Saba, Dr. Anafo, and is it Anafo, and Mr. Al Hassan. We are grateful to all of you for the presentations that you gave us. We would want to acknowledge PSG, Pediatric Society of Ghana, for ensuring that whatever we started last week, have been able to bring it to a successful end today. We are also thankful to UNICEF for also supporting us, PSG, in all that we do and supporting this program as well. So at this juncture, I would want to call on our chairperson for her closing remarks. Dr. May Adabayere, please, your closing remarks, Madam Chair. Thank you.
Thank you very much. And you gladden my heart when you use my favorite name, May. So I would like to thank Pediatric Society for educating us all about measles. Dr. Saba reminded us that we could catch up on our missed immunizations. And Priscilla told us how contagious measles is. 9 out of 10 will be infected when they are in contact with one measles child. She told us about the eyes, the eye infection, and how important it is to look after the eyes. And Mr. Alexander Nyaba Anafo also told us that the room should be well ventilated, the skin should be kept clean, and we should feed our children nutritious diets, and the very young ones, breastfeeding is best. We should also be mindful when you have unvaccinated young children. He told us about the danger signs we should look out for. So I think as a population, we have quite enough information to look after our children who, if they unfortunately have not been vaccinated, get measles. We understand a little bit more about measles. And we thank Pediatric Society of Ghana for this opportunity. And thank you, Selma, for moderating and emceeing this. Thank you very much. Bye.
My pleasure. Thank you, Madam Chair. Thank you very much. So our vote of thanks from the Executive Committee, the National Executive Committee member, vote of thanks for the program.
Hello, everyone. Good evening. Thank you very much for making time to join us for today from the entire National Executive, both incoming and outgoing, would like to appreciate you all for joining. Thank you very much to our panelists and everybody, and all the best as we go through this together. Thank you.
Thank you too for being here. So we are going to take a prayer. We started with a prayer, we are ending with a prayer. So I'll call on my co-moderator, Dr. Bright Daniel, to share a word of prayer with us as we finally draw the.
Let us pray. Our Lord and Master Jesus, we thank you for our lives. We bless you. And we are even grateful for bringing us to the end of this educative session. We ask that all knowledge that we've shared, all information that we've gathered will go a long way to help the health of children that you've blessed this nation with. Any other blessings we ask through Christ.
Amen. And like we always do, PSG and evidence. Shall we turn on our videos and then take some pictures for PSG? Videos, please. Yes. Who is taking the picture for us? Yes. Please, more videos on. I'm looking for myself. Oh.
All right, so I'm taking
Dr. Daniel, are you taking the pictures? One moment, please. Then we are done. Can't find. Are we done?
Not yet.
Okay, I didn't enable. Yes. Wait. Hey,
Okay,
somebody is eating. Yes, are we set? Okay. Thank you very much for being here. Thank you so much. God bless you. See you again in our next Zoom session for our next presentations. Bye-bye.
Bye, Selma.
Bye. Bye.
I just see my pants.
Yes, we can hear you. Bye-bye.
Yeah, is CPD available for this program? Just to be sure.
No, please.
Okay.
Hello, Uma.